Doing that now.
Temperature, heart rate, and end tidal are still elevated. Let's do an additional round of Revanto. It's been 5 minutes.
Here's your third dose of Revanto.
All right, thank you. Temperature is starting to come back down. He's at 38.7. When he reaches 38, we'll discontinue the cooling process. It's been 5 minutes. Let's give our last dose of Revanto.
Here's the last dose of Revanto.
Thank you. Let's get it injected.
Doing that now.
Temperature, heart rate, and end tidal are almost back to normal limits. Let's go ahead and get rid of the ice packs and get him ready to transport to PACU. Great job, everybody, with dealing with this MH crisis. Y'all really function as a team. Laura, thanks.
Successfully managing an MH crisis requires speed and teamwork. The tasks are many and the time is short. Let's walk through the role each health professional should play. OR personnel play specific roles during an MH crisis. Many things must happen quickly, so having adequate personnel is of utmost importance. The first step in dealing with an MH crisis is to stop the triggering agents. The surgeon therefore must quickly stabilize the patient and decide whether to abort the procedure or to continue. In Jake's case, the surgeon had already completed the appendectomy. Therefore, he closes the incision and stands by ready to assist if needed. The anesthesiologist directs other team members in dealing with the crisis. The CRNA or anesthesiologist discontinues all potential triggering agents and hyperventilates the patient with 100% oxygen. In addition, they monitor the patient's routine vital signs. The CRNA or anesthesiologist inserts an arterial line to monitor blood pressure and send off labs and ABGs. In addition, they will watch for signs and symptoms of DIC. Inserts a second peripheral IV for Revanto and other drugs after the crisis starts. Monitors urine color for signs of myoglobinuria. This requires inserting a Foley catheter. Monitors for possible signs of DIC. Puts in NG for gastric lavage. Puts in rectal probe if necessary. Administers sodium bicarbonate to treat metabolic acidosis and hyperkalemia. Lasix to protect the kidneys. Glucose and insulin to treat hyperkalemia. And lidocaine to treat dysrhythmias. Note, however, that dysrhythmias may resolve naturally once hyperkalemia and acidosis are corrected. The CRNA or anesthesiologist should also document medications and dosages, as well as cooling measures and time. The circulating nurse pages the anesthesiologist and additional personnel to the OR, communicates with the lab technicians for all lab work, alerts the PACU and ICU to be prepared to receive the MH patient, puts in Foley catheter, gets all supplies for MDA and CRNA. Supplies are kept in a dedicated MH cart. The dantrolene nurse brings the MH cart into the OR and immediately begins reconstituting Revanto. The MH cart should contain 36 vials of dantrolene sodium for injection, along with the supplies necessary to reconstitute and administer it. Previous versions of dantrolene could take up to 3 minutes to reconstitute. Revanto completely reconstitutes in just 20 seconds, or until solution is clear. Each vial of Revanto should be reconstituted with 60 milliliters of non-bacteriostatic sterile water. Shake the vial for 20 seconds or until the solution is clear. The initial dosage of Revanto is 2.5 milligrams per 1 kilogram of body weight. For a 41 kilogram patient like Jake, we chose 2.5 milligrams per kilogram. At least 5 vials would be administered. However, administration should continue until end-tidal CO2 and temperature begins to drop. You're going to repeat it every 5 to 10 minutes. More may be needed if symptoms persist. For our example, this patient was given 2.5 milligrams per 1 kilogram as an initial dose of Revanto. And once again, this can be repeated every 5 minutes toward a total dose of 10 milligrams per kilogram. More Revanto may be administered if symptoms persist. Having additional personnel on hand will enable the dantrolene nurse to quickly reconstitute enough Revanto. The cooling nurse's job is to ensure adequate bags of ice are available. The quickest action is to bring in bags of ice and place them at the patient's head, axilla, chest, abdomen, and legs. The stomach, bladder, and rectum can also be irrigated with cold saline, as can the peritoneal cavity if it is opened. A cooling blanket can also be used, and the ambient temperature in the room can be reduced. Cooling measures should be stopped once the core temperature drops to 38 degrees centigrade or 100 degrees Fahrenheit. The body will continue to cool naturally, especially when MH crisis is reversed. A dedicated drawer in the MH cart contains the supplies the cooling nurse needs to irrigate the patient. As you've seen, the MH cart is essential to the successful management of an MH crisis. It includes 4 separate drawers, each dedicated to a separate function. The first drawer contains supplies including lab supplies, lines, urine specimen kits, and documentation materials. The second drawer contains 36 vials of Revanto, along with the syringes and other supplies needed to reconstitute and administer the drug. Drawer 3 contains the medications needed to treat the side effects of MH. These include sodium bicarbonate, furosemide, dextrose, calcium chloride, insulin, and lidocaine. Finally, drawer 4 contains supplies for cooling the patient, including a Foley catheter, rectal and NG tubes, an irrigation tray, Toomey syringes, and bags for ice packs. mHouse can provide complete information on what the cart should contain, as well as a poster to be affixed to its side that provides emergency information about MH. It's critical that the MH cart be readily accessible to OR personnel. It should be secured to prevent borrowing of supplies, but never locked. When each member of the OR team does his or her job effectively, the MH crisis can be resolved within 30 minutes to an hour. The side effects of dantrolene include nausea, malaise, lightheadedness, and muscle weakness.